Good evening, everybody. We welcome you all to the bonus episode of WIGIL webinars, where Dr. Sadiq will be speaking in conversation with Dr. Behari ma'am. And I think they both need no introduction, but I will hand it over to Dr. Shruti to still make one. And we will wait for a couple of more minutes for people to join before we start. Thank you.
So it's my privilege to introduce the moderator for today, Dr. Behari ma'am. She needs no introduction, as Manpreet rightly said. She's one of the senior most surgical gastroenterologists in India, and she is currently heading the Department of Surgical Gastroenterology in one of the oldest surgical gastroenterology departments, so to say, in SGPGI. And we take a lot of pride in this matter. And she has a lot of accomplishments, many publications, many, her specialist areas are all known to us. So without much ado, I'll hand the mic to her so that she can introduce the speaker and they can take the discussion forward. Over to you, ma'am.
Thank you very much, Shruti, for a very kind introduction. And a very good evening to everyone who has joined. It is truly my pleasure, honor, and privilege to welcome the speaker for today's talk, Dr. Sadiq Sikora. And he definitely needs no introduction. A surgeon par excellence, a clinician who has inspired generations of budding GI surgeons by his constant striving for excellence, his professional integrity and uncompromising standards, and one of my most respected teachers under whose tutelage I've had the privilege of being when he was a faculty in the Department of Surgical Gastroenterology at SGPGI Lucknow. Dr. Sikora, as we all know, is presently the Director, Department of GI Surgery and Liver Transplant at the Sakra World Hospital, Bangalore. A very good evening to you, sir, and a very warm welcome. I must say that Dr. Sadiq has chosen to speak about a topic that is not a frequent subject of surgical conversation. And I think it is not considered exciting enough. It doesn't talk about any new, expensive, awe-inspiring, flashy technique. It allows for, hardly allows someone to boast about or show off. And yet it remains a very important and fundamental component of everything that goes into, contributes to a good patient outcome. And I'm sure that when he shares with us what he has to share, a lot of it will resonate with all of us and will give us a lot of food for thought and contemplation. So I welcome you, and please share your thoughts on the power of restraint.
Thank you, Anu. Thank you, Shruti. Thank you, Manpreet. You know what? I feel a little troubled that why I didn't think of this kind of a session. I think it is one of the most uh, enlightening kind of discussions which I have seen in the previous three presentations, one of which I couldn't attend. But a case which teaches you something is sort of session which I think would interest all, and I'm really feel really good that I've been invited to share one of my cases which have taught me something. So let me get on with it, and hopefully you may have a lot of discussion. You may have a few brickbats, but nevertheless, this is something which has taught me immensely and has sort of tailored my surgical decision making a lot. Uh, Let me say that slides are not moving. Okay. So what I want to share is that we concentrate quite a lot on developing skills, but we all know that decision making is a critical part which separates the sort of the best from the ordinary. And therefore, you need to concentrate on decision making, and it is a skill that takes time for you to acquire and master. We all say that we first learn how to operate, then when to operate, and finally when not to operate. And this is part of the sort of your surgical journey, which terminates when you know when not to operate. So let me start this story. It's really a story. So in May 2007, when I moved to Bangalore, at 11 p.m., when I was sleeping peacefully, my CEO rings me up, CEO of the hospital where I was working. And he tells me that a patient, young lady, was being operated at another hospital in the city, and there is a crisis, and the family has to make a decision. Can you speak to them and advise? Actually, I'm very wary of giving opinion on telephones, proxy consultations, and this was the last thing I wanted to do. But since he was my CEO, he knew the people personally, so I agreed to speak to them. Room since the last 5 hours at another hospital, and the surgeon has come out and informed them that she may need a massive small bowel resection, and for that, they need her consent. Now, this was really put me in a predicament. I went deeper into the history, found out she has had multiple surgeries, laparotomy at 11 months of age, at 6 years of age for intestinal obstruction. This admission was for evaluation for infertility, for which she was found to have an ovarian cyst. So they did a laparotomy, ovariotomy, and adhesiolysis about 2 weeks back. And now she was in the OT for a subacute intestinal obstruction, which was not resolving. So I've not seen the patient, have had no interaction with the family. There is no rapport. And I'm being asked a very critical question. I have no idea what's going on in the theater. And you can understand my predicament. But since she was very sincere in asking that question, she was referred by somebody I knew very well. So I asked some direct questions. I got some information from the OT that she was stable, difficult to separate the bowel because of dense adhesions, but there is no bowel injury at that time. I drew upon something which I had experienced in the past. So we had a gynecologist from Middle East when I was working in Kerala who came with recurrent subacute obstruction. And we explored her. Ramesh and I worked on it for 2 or 3 hours and we didn't make any headway. Finally, we decided to close up this lady. And miraculously, on day 3 or 4, her obstruction resolved. She started eating and she was well, discharged home. And the last I heard, she did not have any episodes of obstruction. So, just keeping that in mind, I decided to give this advice that ask the surgeon to close the abdomen and do nothing more. I was not sure whether this advice would be taken both either by the surgeon or the family, but this is what I advised. And to my surprise, they conveyed this to the surgeon who respected their opinion and lack of consent for proceeding with massive small bowel resection and closed the abdomen. Patient was transferred to our hospital 2 days later. She was quite sick, fever, tachypnea. She was in sepsis with AKI, coagulopathy, blood culture positive, lung infiltrates, consolidation. CT showed dilated bowel loops and a few collections here and there, nothing very significant. She was managed in ICU, sepsis resolved, parameters improved, and she was discharged after 14 days of admission, taking orally, tolerating liquids and soft diet. But the icing of the cake was, till date, which is about 18 years, she remains asymptomatic, well, with no episodes of subacute obstruction till date. So this keeps on telling me that, how the path veered from one point and spread into two directions. If she had had a massive small bowel resection, you could understand the consequences of that. Having not had that, you saw what has gone in this patient. It could have turned otherwise, but this is what the story of this patient tells. And this is what she gave me at the end of this. She said that you too have a life to live and a race to run. Actually, as a matter of fact, I operated on her for a lap cholecystectomy about 5 or 6 years after the initial thing. And the problem with which she went to the hospital for infertility, she's the mother of a beautiful girl child. I actually I'm in touch with her on LinkedIn, and I asked her for a discharge summary, and she suddenly recollected that time which she was in deep trouble, and she told me, as a matter of fact, she wrote to me that she would like to hear what we discuss on this. So in this, what I learned was that at times it's not about doing what you can do and thinking that your efforts are going to resolve the issue, but sometimes it is worthwhile to step back, look at things, and figure out that is there any other alternative way out. What is interesting is, so this was, I had one incident in about 2005. This was 2007. And a couple of weeks back, we had a patient from Bahrain, a young boy, with a very complicated colonic perforation, which was managed in his country 5 years back. And at the end, he had a Hartmann's procedure done. And he came for a restoration. Actually, he had a very torrid time with a tracheostomy, psoas abscess, multiple surgeries, and nobody was willing to do a restoration. Anyway, we took him up. I did a restoration of it. He did a lot of adhesiolysis. Patient was post-operatively did well for 5 days, started eating, and they were really happy. And then he started having pain, abdomen, and vomiting again. And X-rays showed that there was a loop of bowel which was stuck. I thought it was an internal herniation which he was having. We managed him conservatively for a period of time. And then on day 15, everyone was very frustrated. The family was very frustrated. The obstruction was not getting resolved. I explored this patient. A very bad time, you would all understand. He had a frozen abdomen. As a matter of fact, from that incision, it took me about 45 minutes to start seeing the bowel. And it was really bad adhesions. And after seeing no progress being made, I decided I'll close the abdomen. And I could hear the deathly silence in the OT around me with all the people who were scrubbed with me. Shruti is witness to that. I mean, I could sense that if we can't do anything for him, who would? What a chicken. I mean, we should do something. But I was scared that if we do an inadvertent bowel injury in this patient, it will be catastrophic. And I decided that we should withdraw. And again, guess what? The guy started eating on day 5. He was discharged on day 7. He returned to Bahrain. I have not heard from him, which means it's good news. So let me just share just a very short snippet of another case, Anu, and then we'll get to the final lessons. So this was a 40-year-old man, large HCC I saw in 2009. He was Hep B positive, but no cirrhosis. This is the tumor which he had. You can all realize that it's a huge tumor in the right lobe of the liver, with going into the root of the hepatic veins. I had a very detailed discussion with the patient and his brother, and I had a really good uh, interaction, discuss all the possibilities of what we could do, what we could end up doing, and not do. And it was a great conversation. I was very happy with the interaction with the family. When I explored this patient, I found that the tumor was rock hard, was sitting at the root of the hepatic veins, and I thought that it would be near impossible. Of course, I know a lot of great surgeons, perhaps in this audience, who would take that out, do a phenomenal reconstruction and things like that. But I didn't think it was within my realms of expertise to go ahead at that point of time. And I realized that it would be hard to get a R1 resection in this patient. So I decided to just step back and review. I had a long conversation with the brother, and we closed the abdomen and came back. I had a good medical oncologist. I discussed with him, and he offered this patient an interferon based chemotherapy. And this patient had a dramatic response in 3 months. And there was a shrinkage of tumor, as you can see, compared to the previous scans, of almost about 40 to 50%. And 3 months later, I took this patient up for a hepatectomy and did a right hepatectomy. And the histology was a well differentiated HCC with closed margins. The most satisfying part is he's alive 15 years later on regular follow-up with no evidence of disease. And this is one of his recent scans. And as a matter of fact, he gives me life certificate for my pension at SGPGIMS, Lucknow. So what I want to conclude by saying is that day in and out, we as surgeons actually are taking up something like a war situation. And we need to understand certain rules of the war. And this is this 5th century BC Art of War by Sun Tzu, which talks about the strategies of war. And they are so applicable to what we do. So you can see that we plan for all our surgeries and all eventualities. That is what it is recommended in this. It suggests that you should have flexibility in strategy, which leads to victory. So unless you are flexible, you are bound to lose if you are rigid. And the most important thing is he will win who knows when to fight and when not to fight. So the first lesson which I have learned is the power of restraint, which is the ability to control our impulses, emotions, and actions, leading to better decision making. As a matter of fact, our training is all consumed by the notion that you are a super specialist and you are supposed to perform. Unless you prove yourself by doing something, your worth is not established. So doing is the key word in what we have been brought up in this specialty of surgery. As a matter of fact, doing nothing is considered often a defeat, but I think it's a skill that needs to be mastered and is harder to master. We often forget that we overestimate our capacity to heal, and we should not underestimate our capacity to cause harm. And a lot of times it's seen that both of these are absolutely true. So as a matter of fact, I feel that wisdom is knowing when to step back before moving forward. And this lesson has at least kept me in good stead most of the time. The second lesson, which is actually a part of the first one, is if you want to exercise these options in patients, it is imperative that you have a good communication and rapport with the patient and family. So you need to have a clear communication, defining expectations and establish a rapport. And I think in both the cases which I shared with you, I was fortunate that I was upfront with what I could do or not do and why I'm doing that. And they immediately were on the same page with me to understand what I'm saying and what can be the outcomes of my intervention. Also, we all realize that mutual trust is an important element in a relationship between surgeon and patient. And unless that trust is there, you cannot take decisions on either end of the spectrum. Because this element of mutual trust is the keystone for us surgeons to make difficult decisions day in and out, which we do when we are dealing with difficult problems, and especially the people with HPB uh, surgeons and transplant surgeons who deal with this problem day in and out with significant morbidity and outcome which is uncertain. So basically, both for doing or not doing, you need a good communication and rapport. And finally, I want to tell that as you saw in the first case, I drew from some of the experiences which I had. And I believe we are the sum total of all our experiences. But actually, this session is unique in a sense that a surgical fraternity, we could be a sum total of all our collective experiences. And I feel that learning from each other and each other's experiences, actually, we could be better surgeons and end up making good decisions for our patients. So that's all I have to say. Thank you very much. And Anu, uh, I leave it to you for all your comments and for all the audience to respond to this.
Thank you very much, sir. This was a riveting account, and I think many of us would have started remembering similar patients in our own experience. And actually, for me, as I was listening to you, a lot of aspects of restraint, kept coming up for me. And first and foremost, you said doing nothing. And far from being a passive doing nothing, I would say it was a very conscious choosing to step back and do nothing after doing the exercise of very careful weighing of the risk and benefit for that particular patient in that particular moment in the hands of that particular surgeon. So basically taking everything into the context and then taking a decision, hardly something that I would call passive, nothing doing. It would be a much harder thing to do. So that was the first thing. And before I open the house, open to questions from the audience, I have a couple of questions. The first thing is that usually this restraint becomes more visible during surgery. When we take a decision, should I go ahead, the decision. But if we look at the ambit of this whole stance of restraint, then this ambit is much bigger actually and encompasses and spills over into all the stages of the surgeon-patient relationship. Would you agree with that? Like both the pre-op, the intra-op, post-op, and follow-up. I mean, at every step, this restraint, I think, comes into play. Would you agree with that?
No, I think you're right. And see, when we say restraint, it is basically a sort of state of mind which we should get into, wherein we should be able to step back and review all the things. And then not only be obsessed by the fact that you need to be actively doing something, sometimes just stepping back and letting things evolve so as to be able to make a better decision, you should be able to do that. And I agree with you that, it reflects in many phases of what we do and in our interaction. It could be during evaluation, it could be during counseling, it could be in the post-operative period, when to re-explore, when to wait. I'm sure there are umpteen examples of this, which each one of us has gone through. I think this kind of session helps us reflect back and realize the importance of a certain stance. And once you realize the importance of that, it becomes part of your ammunition. I would say it's part of your ammunition for the war against the disease, which we do day in and out for our patients. And it's an important tool. It's an important ammunition that we should have. It's not that every time it's worthwhile not to do anything is the best recourse, but careful consideration, sometimes this stance would yield equal, if not better results than doing something aggressively at that point of time.
I agree totally, sir, that it is one of the very important tools that we have. And in fact, not just surgery, to my mind, when we are investigating a patient, what investigations to do, how far to go, when we are offering them some new technique of surgery, so the restraint comes in there also. When we are offering them some new drug, that is, still experiment. So how we put those results for them so that they are able to take an informed decision, the restraint from the physician side comes into play there also.
Sure.
I feel. So, as you said, both intra, post-operative, during follow-up, and, trying to do too many interventions too close to time, especially in a patient who has already been compromised or was compromised to begin with. And I think all these things become important more so in, say, asymptomatic patients and patients with comorbidities or fragile for one reason or the other. These things become even more important. And another thing that came to my mind was that, being so important a tool and at the same time being so intangible in, how to measure and how to see, is something that can be taught or learned, or do we have to kind of learn by the pain of not having exercised it several times?
I think, certainly it can't be taught. But I think, as I said, I'm a firm believer that we learn from all the experiences. And I think I tell all the people whom I interact with my trainees and all, that you need to learn from every experience that you encounter during your everyday working, specific cases, special cases, because not necessarily you will have the opportunity to do the same thing at another time, but that experience will keep you in good stead to make a decision in another critical situation. And that's how, you should take the training and absorb all these things during training. And then it may become part of your working ammunition at some point of time.
Yeah, and I think so that is why I sometimes feel that surgical teams should be a nice mixture of young, middle, and older people, so that we can learn different things from each other. And as you said, we can learn from others' experiences. And I especially would like to stress that I really found that your slides about this rapport with the patient. Normally as doctors and especially as surgeons, we feel we are doing for the patient. This is a very fundamental kind of attitude that we have. But we forget that whatever we are, all our clinical prowess and all our clinical discernment and judgment is as a result of the patients. And, they derive strength from us, but from their trust in us, we also derive strength. And therefore, when we invest in a relationship of trust with our patients, it's not just for the patient's sake, it is for us also. It is so much easier to take difficult decisions in the case of a patient with whom we have this relationship of trust that we have been lucky to develop or we have invested in. So I think that too is a very, very important thing. Do you think age has something to do with it? The development of this muscle of restraint?
At least once you cross 60, you have the opportunity to say things in a manner which everyone has to listen. So maybe age has that value. But I think, no, I don't think it is relevant. I think it is awareness of the options that you have. So I think you need to be aware of all the options, exercise all your options, and as you rightly put, that trust, because surgeon-patient relationship is very special. You They put their trust in you to deal with it, and it's a fiduciary responsibility because they are under anesthesia and you are their advocate. And I often tell them that, especially in difficult situations, I tell them that please remember one thing: we are both on the same side. We are not on opposite sides that we need to argue over things. And so let's understand that, and both interests are the same: the well-being of the patient. I think that sometimes goes a long way to quickly, you know, level the field, and they understand that we are both working for the same goal.
I agree so totally. Actually, when I said age, I sometimes when I look at my younger colleagues and I feel that the pressure to perform or to prove themselves is probably felt a little more acutely in that age. And then this doing nothing becomes a little more difficult to take as a decision. I don't know.
Possible.
Maybe.
Possible.
So I think I have taken a lot of time. I'm sure there are questions from the audience. Is there any way that I can see?
Dr. Gomati has raised a hand.
Yes, yes,
I
Dr.
think the
Gomti.
audience can unmute themselves and switch on their videos as well for a good discussion.
Hello. Hi, Dr. Sikora. Once again,
Hi, Gomti.
fantastic, thought-provoking talk, and the pace in which you talk kind of drives the message so strongly into all of us. Thank you so much for that. There's one very interesting point you raised when you said the operating team took your advice in the right sense and followed what you said. I think that means a lot. Something which we all should. I think drawing from that from both ways. One is when somebody gives an advice to take it. Another is if one of our colleagues has decided to exercise restraint, to be able to understand their point of view, or at the end of it just talk to them and find out what the thought process was rather than talking your thoughts to the patient. I think that's something which is very important for us as a surgical community to nurture and develop, both for our own good sense of environment that we can develop, and for patients' trust in us. Because very often we see when somebody has decided not to do, the patient goes to another doctor and they very easily come up with comments as, oh, it should not have been done this way. I think that's something we should all try to draw from what you said. Thank you very much for that.
Thank you. Thank you.
Thank you. I think Dr. Sumana has her hand up too. Hi, Dr.
Hi.
Sumana.
Hi, Anu and sir. Hi. It was really nice. I joined a little later, but I always enjoy your talks. So I just want to put in some of my thoughts into this. That I don't know, maybe I don't know where this came from, but there are 5 stages of becoming a surgeon. Has anybody heard of it?
We are
Yes.
happy to hear from you. Tell.
Okay, so like I mean, I may not be like exactly right, but it's something I'll try to tell you. It's like the first stage when the surgeon is like really excited and wants to do everything, so he doesn't have that fear. So second stage is when he starts doing and making mistakes. So that is when that fear the fear sets in. So they start becoming fearful, and they go back to the first, like say the fear actually takes over, and they hesitate to do things. So that from that stage onwards to reach the 5th stage is where you should say, no, I think I know how to do it, but I think this will not help the patient, so we should not do this. Saying when not to do is what is the final mature stage, and I truly believe in that, because I think if we see, it's not about us, It's never about us. What we are doing is actually about them. What will what will do well for that person is more important than what I can do for this patient. So eventually now, if you see, many of these studies are also coming which are talking about the futility of any procedure. So that is like when you said that, okay, now if I should stop it here, maybe I'll wait for some time and then do it later. That was like an amazing for a person as senior as you to do that. Takes a lot. I mean, I really hats off to you. And then say that, okay, after 6 months or 15 years, I see this patient so well. That gives you so much of happiness. So this I keep telling, and I think everybody should follow this, that no, the patient may come to us, but we should look at multiple aspects of that patient. Especially, I always see this in transplant, and I say that, okay, it's not about one person. We should look at multiple things, like their financial status, their social status, their psychological status. Not just that, okay, somebody is there. There is a person who's come for surgery. There's there they have money, they have donor. I don't think we should, like, I mean, I'm just giving you an example and just say that, okay, let's go and do it. No, there are multiple aspects, because we see and we feel so sad after sometimes when we don't look at all these things, and then you see that, things don't work out well, and you see that the whole family is crumbling. That gives a lot of, you start questioning whether are you doing the right thing in your life. So these are the points which actually should take, I think everybody should start thinking. And I know that what Anu said is that uh, the youngsters have the thing of peer pressure and then the performance. They're like, okay, I want to do this, I've got a chance, I'll do it. No, I think it's better to go slow rather than trying to do just because somebody else has done, I also want to do. No, that is not the question. Because everybody achieves that stage of surgery differently. Maybe a person who is very young may have reached that stage 4, stage 5, but a very senior person may not have reached that stage 4, stage 5, according to me. So it's like, I think it's a great talk, sir, and the discussion between you and Anu was amazing.
Yeah, I agree. It's not a
I
linear.
relate to it so well. I relate to it completely.
So this
Thank you.
complete context, I think, and in that, the patient's choice. I think there also, as surgeons and physicians, we really need to have restraint. Sometimes we sell them a new technique, a new drug, a new this thing, and they might just say no. And we feel, oh no, but this is the best one. This is the new one. It doesn't matter if the patient chooses. They do have that right. And, there also I feel this stance of restraint comes in. Or should come in.
Especially in
respecting.
Indian scenarios,
Yes.
where the family doesn't, the patient doesn't have much role. The family takes the decision for the patients. Unlike the Western world, where you tell them everything and then they take the decisions themselves. Here it is mostly the family, the children, or sometimes the children are at the receiving end. Sometimes the parents are at the receiving end. So it's not easy. It's not at all easy.
So you wanted to say
I
something?
just wanted to make one comment, Sumana. You said it's difficult for you at this stage to take such a decision. Actually, it's easy for me to take such a decision because it doesn't matter. I mean, I do what I feel is right, and I'm open to judgment, and I'm beyond the stage of worrying about what people judge me. But
Yeah, maybe that's right.
okay,
We
yes.
welcome
Shruti
comments
was saying.
from Dr. Vidya, Dr. Piyush, and Dr. Patta. But I just want to play the devil's advocate here and ask. We are talking about youngsters, and this is Gen Z. I'm not Gen Z, sir. But then I've heard this recent term these days, FOMO, fear of missed opportunity. So, what do you say to them? Like, again, amongst cases like this, we often talk about denominators, right? Do you ever feel that there were any missed opportunities in, using restraint, or what's your take on this? Like, and I want to hear
I
it from
mean,
both of you.
let's put one thing very clear.
Hmm.
I mean, whatever Gen Z or there are many these things and all, but let's put it as younger generation is immensely talented. They are really good at what they do, much better than what we were at that stage. There's no doubt about it. The point is not that whether you should do things or not do things. As I said, that you learn from everything. And one of the things which you may keep in your mind or as one of your tools is when to step back and not feel shy about it, not feel any less about yourself having stepped back. And that is what I just wanted to communicate. And as I said, that being 60, you are allowed to sermonize a little bit. So it may sound as a sermon, but it doesn't mean that you don't do things. Certainly not. I mean, you do what you have to do. But there are instances where you may be called upon to use this tool, use it judiciously. Don't feel any less about not doing anything.
Yes, that's what I said. It's a very considered not doing kind of, like choosing to not do. And like in the second case, it was a matter that time the situation was not right. You went ahead and did the procedure 6 months down the line, and it was so much better. So it's not just about not doing. So, and I agree about the younger generation. I didn't mean like that at all, too. I know, and all of them, every generation stands on the shoulders of the previous one and therefore can see further. So,
approximately more than
other questions from the article?
Yeah, Dr. Vidya, please, if you can. Yeah.
Yeah, thank you for asking me to speak, though I'm, I'm not even a surgeon. So I just wanted to, catch on that point that Dr. Sadiq made right at the end, that this program is a attempt, this kind of programs are an attempt at a collective experience rather than just having our own, working on our own experience. So a little bit addition to that, I would say that something that many senior surgeons do, but sometimes I don't see the younger ones do so much, is that you take the collective experience of those who are inside the operating room. Like you may have a oldie anesthetist like me, who's seen probably more laparotomies than somebody has done, or seen some scrub nurse who's assisted many more complex GI surgeries than what thing. So I think that is another message should go out, that there's no shame in taking a pause and taking input from the others who are in the operating room when you're in a bad place. And most of us are quite happy to okay, I am a big mouth, so I'll probably say it even if I'm not asked. But a senior nurse or some other anesthetist may actually have want to say something, but they don't say it because it doesn't seem like it's welcome. So I think that's another way. And like it's an old story, we don't have to learn from our own mistakes, we can learn from others. So I think experiencing these things when other people are operating, like because I learned ultrasound guided nerve blocks very late. So I try to learn it every time there is a block going on in the operating room somewhere else also. I'm kind of, living through it or vicariously doing it. So like that, if surgeons also vicariously experience difficult cases with other surgeons, especially if they have an opportunity like somebody like senior like Dr. Sadiq. Oh, my case is over, my OR is over. Instead of that, that will also add to our collective experience, because you'll remember something. Okay, it may be anecdotal, it may not be a meta-analysis, but you'll remember that this thing happened in that situation. And this is what Dr. Sadiq did to bail out. And probably that will work for me for this situation. So that's my 2 cents. Sorry for taking the question.
So can I just make, Vidya, anyway, you're doing a marvelous job in marvelous medicine. But, the point which you raised are very, very important. And I am part of one of these non-technical skills for surgeons. As you are well aware, there is a non-technical skills for anesthetists. This stresses upon this very thing which you touched upon, which is teamwork and communication. And it needs that to be developed in surgical teams and in all teams and across teams. So it's a very important aspect of what we do these days, wherein inputs from all, be it senior, other people, should be welcomed, should be weighed in, and then appropriate decisions be taken after that. But I totally agree. I know of anesthetists who watch the laparoscopic cholecystectomy screen and nod when you are in the right place and uh, vigorously shake their heads when you are in the wrong plane and relax when you get back to the right place. So, yes, we should take their inputs definitely.
Piyush sir and Pata sir.
Is Dr. Piyush there on the?
Yeah, he's on. Piyush sir, can you unmute and share your experiences on this topic? Okay, while we have him back, Pata sir.
Yeah, good evening. It's always nice to listen to Sadiq, every word of his. The Vigil group interests me because one, of course, is all youngsters. A bunch of youngsters are started off this program, and they have started with introspection sort of a thing. Difficult cases we face and difficulties we are facing. This is not like any other group where they want to share knowledge and all that. And interestingly enough, after the initial sharing of troubles you have gone through, now you are calling senior people and just to learn from them how they got over them and at what level they are. It's quite actually, if you many of you I think are independent, some of you are under an umbrella and some of you are working in teams. Coming to Dr. Sadiq's uh, lecture, see, ability to do something is a very very uncertain term. I know if Dr. Sadiq was dealing with the certain liver lesion in SGPGI, his decision will be different. If Sadiq is in Sakra, it will be different. And if he's in Sri Lanka, it will be different. It's not just the ability to do, you have very good assistant, we have very good teams, you have good backup. And that apart, the corporate sector is a different ball game. And I think a lot of these things come into play. And many of you from Vigil are in different uh, types of hospitals and different seniority positions. Some of you are independent at a very young age. Decision making is not that easy. But Dr. Nandi always used to say that you should always attempt a little more than what you have done before. Otherwise, you'll never know where you stand. I don't know whether Sadiq will agree with that. He said you should always keep progressing. Otherwise, you draw a line. The unfortunate thing in corporate sector is if you don't dare, in due course of time, because you have always been watched by people, think that is your level, that is your limit, and you never grow beyond that. It's not that easy. So there are many factors. I think things are, of course, as they always say, that you should be continuously training, and you should. It's mandatory that you should work under a certain senior till a certain level. These days, many individuals want to be independent early in life, which isn't the right way.
Where is?
So it's a bit complex. But having said that, it's very interesting to watch young surgeons speak their mind out, and it's a lot of things to learn from seniors like that, Sadi. Yeah.
Piyush sir.
Dr. Piyush?
Yeah, so very interesting. I joined in a bit late, so I'm not sure what transpired, but the general, I get the general gist of what's been discussed. So a few comments. The first, when I was a resident in surgery, Professor BML Kapoor said, uh, it's not important to learn when to operate. It's important to learn when not to operate. And he used to say this repeatedly. He used to say that, doing a futile procedure is no good. Doing a laparotomy just for the heck of it and saying I've got a negative laparotomy is not a great idea. We know there's studies to say that, if you don't have an X amount of negative laparotomies in a patient with acute appendicitis, then you're probably missing patients with acute appendicitis. And there's data of that kind. But this was one lesson that I learned. The second lesson that I learned was related to, holding back. Was when we had a patient with surgical obstructive jaundice and pretty bad portal hypertension. And we explored this patient and tried to get to the bile duct. And at some point in time, and he'd already had a shunt done. And we kept trying to get to the bile duct, but couldn't. Finally, I think somebody stuck a needle somewhere and drew some bile, and somebody said, let's do a hepatic vaginostomy. And Dr. Nandi said, we'll just put in a T-tube and come out. We've lost enough blood. We put in a T-tube and came out and decided to go back in a few weeks, a few months later. I think we went back after 3 or 4 months. And this time there were 10 units of blood arranged, and there was all kinds of preparations done, and arterial lines and central venous lines put in. And it was so easy. We just traced the T-tube down to the bile duct. There wasn't a drop of blood, and extended the incision up and did a parapagogenostomy. So living to fight another day, there's no shame in it. The third aspect that is another story that I want to tell you about. Two of my professors who often didn't see eye to eye. And the senior professor came around on a round and said, what does this patient see a rectum? Young person, 26, 28 years old. And he said, I'll do a rectal. He did a rectal examination, said he's got a fixed growth. Do a colostomy and discharge him because he's obstructed, partly obstructed, and he'll get into obstruction. So we tried to fix him up for an emergency procedure, but as usual at AIMS, getting the anesthetist to be convinced about doing a colostomy in a patient who doesn't have peritonitis and frank sepsis and things like that is a difficult job. So it didn't get on to the list that day. The next day, the second consultant came around and said, so he was told this patient's going to be discharged today. And he said, why? I'll do a rectal. And he did a rectal and said, I think we should try and take it out. He's a young person. He didn't tell the resident to go and tell the other consultant that this is what he plans to do. He said, I'll talk. And they both talked to each other in front of all the residents. And it was agreed that he'd be posted in the next OT. And he was posted in the next OT. The consultant who thought he'd be able to excise the growth made an attempt. But in that attempt, opened up the posterior pelvic venous plexus. And there was a huge amount of blood. We lost a lot of blood when he finally said, I think we'll have to call the other consultant in. And the other consultant who was senior came in and didn't say a word. Didn't say, I told you so. You don't listen to me. And you're now in a soup. So why are you calling me? He didn't say that. Just scrubbed in. And the two of them together struggled for 2 hours. Controlled the bleeding, packed the patient, came out. In the audit, in the mortality morbidity conference that used to be called back those days during in that particular unit, there was discussion on this patient. And the second consultant owned up to the fact that he'd made an error in front of all the residents. So I think to own up a mistake, to be able to assist each other, to be able to look at the positive side and not only the negative side. Here was a person who was young, and one person thought he could try and exercise it. The other person said, okay. The person got into difficulties, and he didn't pull him down. He just decided that both of them needed to get along and do what was right for this particular patient. I think these were three interesting and good lessons that I learned. And I think all the residents who've worked with me at any point in time have heard at least two of these stories, if not the third. Thank you.
Thank you, sir. Thank you very much. Do we have some time, Shruti, or
Yes,
can
ma'am.
we
I
take
think
a
we
couple of
can.
questions?
Yeah.
So are there any questions or comments from the audience?
Anyone else?
While somebody is looking for questions, I want to. Patta is a great friend, but Patta, not doing anything is also growing. So it's not that when you do more than what you did previously is growth. I feel that is also part of growing. And I agree with you that depending on the setup, you are prepared to take that extra risk or not prepared to take that extra risk because the answerability is different. But it doesn't mean that we do compromise the management in any case, in any of the situations. So partly agree, but we'll discuss this out of this.
Dr.
Can
Nandi
I talk?
yeah.
Please. Okay, good evening, all seniors. It was really once again a nice session and many learning tips from Sadiq Sikora sir as always. And it was very much nice to listen to his talk. I think we all must have remembered all such situations. And we have also come across recently, I can remember there was a patient who was operated at the age of his 2 days and then 8 days for duodenal atresia and everything. And at the age of 10, 12, he came to us with weight of 14 kg and with a stoma. And for the reversal of stoma, we took 4-5 hours just to know the anatomy, what is attached to what and the bowel. And then we refrained and came back. What I wanted to just suggest one thing is sometimes what I feel is remaining flexible to take suggestions from the juniors also from the seniors. Of course, we call seniors and take the advice what is to be done, but the juniors also sometimes help, and then their suggestions also should be taken, and we should be flexible to take their suggestions also as it was suggested by madam also. And second point, I think we can choose to do some other procedure also, some lesser procedure of lesser extent. Like for example, recently we had planned a right hepatic resection for atrophied right lobe with hepatolithiasis and everything, and cholangitis. And during the dissection to reach the hilum, it took a lot of adhesiolysis, bleeding, and later on it was realized that why not to do only hepaticojejunostomy instead of doing right hepatectomy. And sometimes changing the decision should be also should not be considered as a lesser surgery or not optimal surgery in that situation.
That's a very, very valid point. And in fact, I consider that part of restraint too. Changing, none of your decisions are written stone. It's a dynamic process. And if you have new factors, you change. So that too, according to me, is part of restraint,
Yes.
actually.
Sadiq, I have a comment to make because Dr. Nandi often used to say that, because as I see a lot of youngsters here, that if you are starting independent GI surgical practice, GI surgery is not a simple specialty at all. And especially when you're out in the open, where a lot of general surgeons will try to, test your metal. He always used to say the first 6 months don't do more than appendicectomy. A little. First 6 months, just keep doing that. People will recognize you. You're very good at these things, and after that, whatever you do, whatever goes wrong, they'll accept it. Straight away, you take a liver resection or something, some portal hypertension, and get into trouble. You're troubled forever. I think that's a very very important point. When I joined after the All India Institute, I went and joined SIMS Tirupati. I don't know. Every day I used to get a referral of 3 or 4 liver metastases. Because the surrounding area, I didn't know what to do actually. But, the most important thing for any younger GI surgeon is ability to tackle emergency surgery. Because when it comes to, I think that's where when people, are in a bit of a trouble and they refer or they call you or whatever, and slowly you grow when you save patients or save doctors while operating emergencies. I mean, these are 2 points I want to highlight, Prasad.
Thank you very much.
Dr. Kush.
Yeah, hello. Hi, everyone. Thank you, Dr. Sadiq. Thank you, Professor Anu, for a brilliant talk and discussion. So, an additional point which I would like to add is that in today's age, we have so many things, which can make us better prepared for the procedure. Say, for example, imaging, the current quality of scans that are available. So, my point is that read the imaging properly, perform the surgery on the imaging first, and then perform it on the patient. Plan each and every step on the imaging so that, like step 1, step 2, step 3, where you're going to encounter difficulty. That can also be, found out on the imaging that, okay, these are the areas where I'll encounter difficulties, and have a plan B decided pre-operatively. Then when you go for the surgery, and if you face difficulty in that area, resort to plan B, and if not, and then ask for help. So, in this way, you can be very well better prepared for the procedure.
Thank you, Kush.
Anyone else wants to comment?
Dr. Kailash Kordia is here. He's a faculty at AIIMS Delhi. If he would like to make a comment or say something.
Hello, hello, good evening, everyone. So, very interesting and brilliant talk, and very good comments by all senior faculty. So, I want to say that at the sir said what not to when not to operate. This is one of the most important thing which should learn by everyone. Okay, thank you.
Thank you. And Dr. Soumya, if you would like to say a couple of words.
I don't know what to say. It's just been a privilege to work with sir. I think I've learned a lot from him. I have made a lot of mistakes, and when the vicarious learning comes, I think the whole team is doing it my sake. Sir says कि सौम्या के हाथ से हर एक complication हो चुका है. The entire spectrum has been done. So yeah, possibly I'm the one making the mistakes, and people are learning from mine. And but yes, I think in the 11 years that I've worked with sir, I've learned a lot about when to say that we should not operate, and I think that's the mark of a very mature surgeon. There are many times when this happens in the unit, and we do discuss it out. And I would definitely like to say that he takes our inputs too. There's so many times we talk it out. He's open to discussion. He's open to suggestions. When Dr. Kishore was working with us, there were times when we would sit down and talk so many times. They had differing opinions. But he would listen to all of us, and then we would come to a joint solution. So it's possibly, yes, the combined experience and the combined decision making, which really helps the team go forward. So yeah, that's all. That's my bit. Thank you.
Soumya, that's a very important point that you said about the communication within a team, so that the atmosphere is safe enough that everybody can offer their opinion, knowing that it will be heard, which I think is a mark of a great leader, to be able to develop such teams. And of course, the team members, that they are receptive enough for that. So both ways, it's a mutual thing. So any more questions? Are we taking any more questions, or I think it's time?
Any last minute comments or questions from anyone? I see of trainees who worked with sir. Anyone has anything to say? Just volunteer. I'm not going to call your names.
Good evening, sir. Good evening, everyone. My question being the importance of counseling the family when we change the plan or when we are applying restraints. How do we counsel the family and tell them that right now we are not going to do anything and not go ahead with the surgery?
Yeah, so as it was mentioned, that basically you need to be prepared for all exigencies. That means doing nothing may also be a consideration when you are planning surgery. And if you can discuss that at that time, that is the best. But sometimes you don't maybe have not considered that option. And some findings have sort of pushed you into taking a decision like that. I think it's always important. You can always discuss with the family at that point of time. Be open about it, that what has prompted you to take that decision. And as long as you realize and you're aware that it is in the best interest of the patient, you should be able to communicate this to the patient and to the family, definitely at that point of time. So it is possible uh, to do that. And the best part is as long as you are not doing any harm, everything is fine. And at least you are not uh, answerable to a mishap, which would be more difficult to explain or answer to the family.
Does anybody else have any
Right.
questions?
I want to add a point, ma'am, if that's okay. Sir, good evening, sir. It's been a privilege being trained under you, sir, and as usual, great talk. And more than being fan of your surgery, I've been fan of your decision making, sir. I personal experience of my father-in-law itself. When I got to him a pancreatic head mass, we were at the end, blind, and what to do about that because the biopsies were coming negative, but it looked very much malignant. We took him up for laparotomy after convincing the relatives and everything. After 4 hours of dissection and everything, we realized that even though we had got the control of the vein, doing the venous reconstruction and doing entire surgery and putting the patient with 45% ejection fraction at risk, you decided that we should abandon the procedure at that point. I was wondering, we have spent so much time on this, it would be difficult to convince the relatives that we did not do anything, we just did laparotomy, but patient was on the table for 4 hours. But later I realized how right the decision was. Today he is doing well, and the scan we see that the lesion is regressing. I think that was the best decision for him, and this is just an example of the amazing decisions which I have seen while I was working with you, while I was being trained under you. uh, if we were not scared of you, I think we would have come to you for non-medical problems also for your decisions, sir. Great talk, sir. Great talk.
Thank you, Anand. I mean, is it a sort of contrived event with everyone from the unit being present?
The people just love you too much, so they're here on their own. We didn't ask anybody to come.
Sadiq, I didn't know you scared people.
Yeah, Piyush, you should say this to everyone. They use this as an excuse.
I thought you were such a benign and
Correct.
simple person. I never knew you were so. Oh, maybe I don't know parts of you.
Sir, you work under him, you'll get to know, sir.
We build it up in our head also, sir.
Okay,
I haven't worked under him, but I have worked with him.
No, Piyush, you know the right person.
Good evening, sir. Manmohan here.
Hi, Manmohan.
Nice talk as usual. I just wanted to put it that the only thing which used to scare us was your "Arey yaar." So what had gone wrong? But rest, it was all great working with you, and still we remember and teach my students what we learned and try to pass it on to them. And it's all with an experience that all the things come what you had said. And as you said, age now it doesn't matter. people are judgmental about you. So I think slowly, as you gain experience, that comes into the being.
Thank you.
Thank you, sir.
Shruti, may I make maybe a last or a penultimate comment,
Yes,
which I
ma'am.
feel like saying? We've
Yes.
been talking about age. I think a long career actually kind of gives you a certain humility when you see time and again, if you do things more than what nature allows in that moment, results are never good. Because these very fundamental processes of healing, repair, regeneration, nature has perfected over millennia. And as surgeons, what we can hope for is that we learn more and more to tune in so that, we can follow these rhythms and we intervene when it is most conducive and we do as much as it allows. So, if we are lucky, we get that. So restraint comes like automatically because you see, you learn.
Thank you, ma'am. Very valid comment. And thank you everyone for joining in. It was a very enlightening discussion. And, I'm very thankful for all the wisdom shared. And we'll wind up this session and we'll join in again next month, the first Tuesday of May, with another enlightening talk. And see you all then. Bye-bye and good night for now.
Thank you. Thank you very
Thank
much.
you.
Thank you.
Everyone.
Thank you, everyone.
Bye-bye.